So what about for older patients? This series of treatments looks very similar to the one I showed you for younger patients. Initially chemotherapy, then rituximab came along, then bendamustine. It was shown that bendamustine plus rituximab was actually better than R-CHOP, which was an older regimen that we use. Some patients are treated with a drug called lenalidomide plus rituximab as an alternative approach that may be a little bit gentler. And then patients tend to get maintenance rituximab, which we know keeps people in remission longer than observation. So if you look here, this is that real world assessment of what people are getting in the community by Peter Martin and colleagues. And this was older patients. So you can see over time, initially back in 2011, we used a lot of R-CHOP. But over time, BR has become, for sure, the most common regimen that we've been using in older patients. So this was an interesting study that was presented at our meeting this year as well. You can tell this meeting was full of information on mantle cell lymphoma. And it asked the question, well, is chemotherapy better than using the BTK inhibitor ibrutinib plus Rituxan compared to Rituxan plus chemo? This was a study done in Europe where they're still using ibrutinib. Again, I mentioned in the US, we're using more acalabrutinib or zanubrutinib because they're a little bit better tolerated. And before patients were treated, the investigator, the person treating that patient, had to say which chemotherapy regimen they were going to use, R-CHOP or BR. And patients got one or the other, and then they got maintenance with rituximab maintenance. In this arm, they got ibrutinib with it. And then the patients on the ibrutinib arm then continued the ibrutinib until their disease was progressing. So the conclusions from this study showed that ibrutinib plus Rituxan actually looked better than standard chemotherapy. However, when they dissected out the results, they saw that bendamustine plus rituximab looked very similar to ibrutinib plus rituximab, where R-CHOP was not as good, and that was driving the difference. So basically, it said, you could choose either of these options for your patient, and there were certain subsets where ibrutinib was better, and those were patients who had that TP53 mutation that I mentioned that makes chemotherapy probably less effective. But for patients who had disease that was growing more rapidly, that Ki-67 fraction, ibrutinib was less effective in that group, and those patients did better with sort of more standard chemotherapy. So this study also looked at combining acalabrutinib, the BTK inhibitor, plus bendamustine plus rituximab. The same study had been done in the U.S. called the SHINE study using ibrutinib instead of acalabrutinib, and that study showed that adding ibrutinib kept more people in remission, but the toxicity was significant, and the conclusion of that study was we shouldn't use ibrutinib anymore, and we probably shouldn't combine it with bendamustine plus rituximab. This study, however, we're looking at the newer BTK inhibitor acalabrutinib, and patients either got bendamustine plus Rituxan with maintenance rituximab or the same plus acalabrutinib as long as they were continuing to respond. So this study did in fact show if you add acalabrutinib to bendamustine plus rituximab, more people stayed in remission. That's called progression-free survival. And the toxicity profile appeared to be more manageable using acalabrutinib as opposed to ibrutinib. We need some longer-term follow-up to make sure that the toxicity doesn't crop up later, but this really does support the use of this combination, particularly in older patients who may not be good candidates for that Ara-C-based drug that I mentioned before. So again, there is a bit of a controversy here whether we should use bendamustine plus Rituxan followed by Rituxan and then save the acalabrutinib for when the disease comes back, or give everything together up front and see if we can get a longer remission. And we need more data to really help us figure out whether sequential or combined approaches are going to be the best way to move forward in mantle cell lymphoma. So in summary, for older patients, we use bendamustine plus rituximab as the most commonly used combination in the US. And now we know you can add acalabrutinib with the caveats that I just mentioned, and then patients get maintenance Rituxan with acalabrutinib. So I mentioned that TP53 mutated, so we know that patients do not do well with standard chemotherapy when they have these mutations. And this was a study from Memorial Sloan Kettering by Anita Kumar. And here they combined 3 novel drugs, the zanubrutinib, which is the BTK inhibitor, obinutuzumab, which is a cousin of rituximab, it's a CD20 antibody, and then another drug called venetoclax. And basically what they showed in this study, it was a small study, but they showed very good responses in these patients who have more aggressive disease. And this has now become sort of a standard option that we will offer patients who have TP53 mutations.